Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this video, we're going to go through shock in terms of pharmacology. We're going to go relatively in depth into adrenergic medications and cholinergic medications. Let's start by talking about shock. Shock is a state of inadequate cellular perfusion. That's that bottom line. Shock is a state of inadequate cellular perfusion, meaning the cells are not getting enough perfusion, in other words, enough oxygen. Now, there are three components of the cardiovascular system, which is responsible for delivering oxygen to each and every cell. There's the heart, the blood vessels, and the blood itself. We need all three of these to be working perfectly. We need the heart to be pumping, we need the vessels to be intact, not too dilated, not too constricted, and we need there to be blood in the vessels, and the blood obviously needs to be proper, it needs to be well oxygenated, the red blood cells need to be oxygenated, there needs to be enough red blood cells, et cetera, et cetera. But let's talk a little bit about how we manipulate the cardiovascular system to affect the blood pressure. Because again, we said shock is about getting oxygen to the cells. We need to have adequate blood pressure to do that. So let's start with the three components of the cardiovascular system: the heart, the blood vessels, and the blood itself. I can use each of these to increase or decrease a patient's blood pressure. How would I do that? Well, if I speed up the patient's heart rate, then I'm going to increase their blood pressure. If I lower a patient's heart rate, very often I will decrease the patient's blood pressure. Next, we have the blood vessels. If I vasodilate, I will decrease a patient's blood pressure. If I vasoconstrict, I will increase a patient's blood pressure. And that one's pretty easy to understand. Think of it like a highway. If I go from 2 lanes, if I dilate out to 4 lanes, the traffic comes down, the pressure comes down. If I do the opposite, if I go from 4 lanes and I put it down to 2 lanes, it's going to get congested, it's going to be more pressure, the blood pressure goes up. And the last is the blood. That one's also pretty simple. If I go ahead and I give a patient fluid or blood, then the blood pressure comes up. That's a universal fact. If I give a patient fluid or blood, it's going to come up. If I take some away, if I give you a diuretic, most of the time it will come down. So these are the three components of the cardiovascular system, and this is going to be very relevant throughout pharmacology. Today, when we talk about shock, and in a future lecture, when we talk about high blood pressure, these are the three ways that we use to manipulate a patient's blood pressure. So let's go ahead and start with shock. There are three subclasses, or there are three primary classes of shock. There's hypovolemic, cardiogenic, and distributive. There's a fourth one, which is obstructive, which is a mechanical issue, something that's physically constricting the cardiovascular system. We're not going to discuss that today because this is pharmacology. So let's talk about the three primary methods of shock that we're going to discuss, which is hypovolemic, cardiogenic, and distributive. Hypovolemic shock is where a patient's simply down on fluid. It could be because they're bleeding out. It could be because they're severely dehydrated. Cardiogenic shock is where the pump is failing. It could be it's failing because of an MI, because of heart failure, or something else. And finally, distributive shock is a case where the patient is severely vasodilated. It could be because of septic shock, anaphylactic shock, neurogenic shock. For any of these reasons, the patient is severely vasodilated. In all of these cases, the blood pressure is down. Hypovolemic shock, I don't have enough volume, blood pressure is down. Cardiogenic shock, the pump's not working properly, blood pressure is down. Distributive shock, the vessels are way too big. So again, like our traffic, if I had a nice steady flow of traffic on 2 lanes, suddenly I open up to 4 lanes, now the traffic went way down, the blood pressure went way down. So these are the three primary types of shock. You may see your textbook uses other types of shock like septic shock or anaphylactic, but those really fall under distributive shock. So let's talk, now that we know the three primary types of shock, we're skipping obstructive. We know that each of these match up to one of the three primary components of the cardiovascular system: the heart, the blood, and the blood vessels. So now let's talk about treatment. Hypovolemic shock, we'll start there. If a patient is down on blood volume, then we give them blood. If they're down on overall volume, we give them fluid, NS, LR, whatever it may be. We're going to replace what's missing. That's the simplest type of shock, hypovolemic shock. Moving on from there, we have cardiogenic shock. This one's a little bit more complicated. If I give this person fluid, like I did to the hypovolemic shock, am I helping? No, because this person is in cardiogenic shock. Their pump is failing. Giving the pump more work to do by giving more fluids is not the best idea. In this case, the best idea is to give a beta-1 agonist, such as dobutamine or isoprotenolol. Next, we have our distributive shock. Distributive shock is where the vessels are way too big. Over here, we have two treatment options. We can fill up the vessels because, again, the vessels got way too big, so let's picture it as half empty. So I could top it off. I could give the patient fluid. The other option is I can vasoconstrict the vessels and make them smaller. In this case, we do both. We give the patient fluids and vasoconstrictors. A vasoconstrictor would be something like norepinephrine, which is Levophed. Now, I just want to go through real quick. So we learned three types of shock. We learned three components of the cardiovascular system, and we learned three treatments. They really need to plug in exactly this way because, for example, if I give a hypovolemic patient a vasoconstrictor, will that help their blood pressure? The short answer is yes. If I give you a vasoconstrictor like epinephrine and you're having traumatic blood loss, it will bring up your blood pressure, but it's not going to fix the problem. So will we do that? Maybe if we need to if the patient's really critical and we need just a few more minutes to buy some time, we might put them on an epi drip, but that's not going to fix anything. We need to give them volume, and we need to obviously fix the cause that got them in this situation in the first place. Moving on to cardiogenic. We talked about this a little bit. We said that giving this patient a beta-1 agonist like the butamine is the best because the heart's failing. Let's make the heart beat faster, harder, stronger. And I also already mentioned that fluids would be a bad choice here because the patient's heart is failing. We don't want to give it extra work. Will we give this patient fluid? Sometimes yes. Ideally colloid that we don't have to give as much, but sometimes yes. Again, even though that's not the ideal answer, sometimes that is part of the problem, that maybe they are actually down on fluid. Plus, maybe we just need to do something right now to get their blood pressure up. Would we give this patient a vasoconstrictor? Again, that's actually going to make the work of the heart that's failing in cardiogenic shock. It's going to make the work of the heart go up even more. If I give you a vasoconstrictor, we're not going to go too deep into that patho, but if I give you a vasoconstrictor, then the heart has to squeeze into these really tight vessels, which makes it very hard for the heart. So in that case, I'm going to increase the work of the heart, but would I bring up the blood pressure? Yes, I would. Will I do that? Sometimes yes. It's not ideal, but sometimes yes. At no other choice, we will do that. Finally, distributive, we already said we would use both treatments, so there's nothing to go over there. This is pharmacology, so I'm just going to real quick touch on assessment because you may see this as part of your pharmacology course. Assessment for a patient in shock should always start with ABCs, airway, breathing, circulation. Make sure you're checking all their vitals. We're going to assess primarily their heart rate and their blood pressure to see how they're doing in shock. We want to see the blood pressure coming up. We want to see the heart rate coming down. We may also use MAP, mean arterial pressure, in order to determine how to titrate or taper our medications. A MAP can be calculated as 2 times diastolic plus systolic divided by 3, just in case you need to know that. You can pause the video or slow down if I said that too fast. But most of the time when we're titrating and tapering these medications for shock, we're using either the systolic blood pressure or the MAP. And then one other lab I want to specifically mention that's relevant to shock is a lactate. A lactate tells us if the patient's cells have switched to anaerobic metabolism. If the cells have switched to anaerobic metabolism, I know 100% the patient's in shock because the cells are not in aerobic metabolism. Therefore, if I see lactate, I know the patient's in shock. A normal lactate is less than 2. Between 2 and 4 is generally considered inconclusive, and 4 and up is considered positive. So now let's move into a little bit more of A and P before we get to pharmacology. So let's talk a little bit about adrenergic and cholinergic. These are 2 different receptors. Adrenergic are the receptors of the sympathetic system. Cholinergic are receptors of the parasympathetic system. The primary neurotransmitter of the sympathetic system is going to be norepinephrine, and of the parasympathetic system is going to be acetylcholine. Let's do a quick review of the different receptors. Again, this is very relevant to the pharmacology we're about to get into. Alpha-1, if you give an agonist for that, I'm going to get vasoconstriction. If I give an antagonist for that, I'm going to get vasodilation. Alpha-2 is a little bit hard to understand. Alpha-2 actually fights the sympathetic system. So alpha-2, if I give an agonist, I'm going to get less sympathetic response. If I give an alpha-2 antagonist, I'm going to get more sympathetic response. So a little bit backwards there. Beta-1 is going to be inotropic and chronotropic cardiac effects. There's another word here you should know. Contractility is how hard the heart beats. Inotropic is usually used interchangeably with that, also about how hard the heart beats. Chronotropic is related to time, like chronological order. It's the same root of the word there. So basically, beta-1 is going to make the heart beat faster, harder, stronger. Beta-2 is going to bronchodilate. Let me back up one second. Beta-1, if I give an agonist, it's going to make the heart beat faster, harder, stronger. If I give a beta-2 or a beta-1 antagonist, the famous beta blockers, if I give that, it's going to slow down and make the heart beat less fast, less hard, less strong. Beta-2 is bronchodilation. So if I give a beta-2 agonist, I'm going to get expanded lung capacity and improved breathing. If I give a beta-2 antagonist, I would prevent breathing. Obviously, there's no such thing because we never want to do that. There is a quick trick I'm sure you've learned already. Beta-1 is the heart because we have 1 heart. Beta-2 is the lungs. We have 2 lungs. Beta-3, is the detrusor muscle relaxation. That's what it you get if you give an agonist in that. And again, there isn't an antagonist for this, at least not that I'm aware of. Next, let's move on to the effects of the adrenergic system. If I activate the adrenergic system, meaning I put the patient into fight or flight mode, I'm going to get dilated pupils, which is mydriasis. I'm going to get bronchodilation, tachycardia, hypertension, and decreased GI activity. So let's start actually looking at some medications now. We're going to start with the adrenergic receptor medications. So first class we have are the alpha adrenergic antagonists. These are known as alpha blockers. So we start with really three subclasses of drugs here. We have the uroselective, which are the ones used for BPH, benign prostatic hyperplasia. We have cardioselective, that's the ones used for hypertension. And then we have ones that are used for both. And there are more drugs that I could have added to this list, alphazocin and others, but these are probably the three most common ones that you'll see. Tamsulosin is the BPH one, prazosin is hypertension one, doxazocin can go both ways. The mechanism of action here we already discussed. It's a blocker of alpha-1. Alpha-1 causes vasoconstriction, so this blocks the vasoconstriction. For BPH, this also works by relaxing the prostate. What are these medications used for? We already covered BPH and hypertension. The main side effect with these medications are orthostatic hypotension and reflex tachycardia. Again, anytime you see orthostatic hypotension as an RN, make sure for test purposes you're ready for questions like make sure you get up slowly from a seated position. And these medications also cause sexual dysfunction. So again, it would be appropriate for a test to ask you which of the following medications would require a patient to get ED counseling. Phentolamine is another drug that's in this class. This is used for extravasation. This is where a vasoconstrictor that we're going to learn about at the end of this lecture leaks into the local tissue. So we can use it there to reverse that. And phentolamine is also used to diagnose a pheochromocytoma. Next, we have the beta blockers, the the beta-1 adrenergic antagonist is the technical name. And again, we have three subclasses here. We have the non-selective. These are going to, even though they're meant for beta-1, they have a little bit of spillover effect on beta-2. So if they have a little bit of spillover effect on beta-2, the beta-1 is going to make the heart not beat as hard, as fast, and as strong, which is what we're looking for. But because it has a little blocking of beta-2, it might mess with your respiration. So definitely be careful giving propranolol to a patient that has underlying cardiac issues, and that's a very common test question at the nursing level. Then we have our cardioselective, metoprolol, atenolol, esmolol. There's about a dozen or more beta blockers. I didn't list all of them, but these are the most common ones. The cardioselective medications are less likely to have any effect on beta-2. Ideally, they wouldn't have any effect at all. It's in theory possible, but generally they wouldn't. And then we have our non-selective with vasodilating effects. The two over here are labetalol and carvedilol. These are non-selective, but they also vasodilate. When you get into heart failure, you get into talking about afterload, we're going to understand more about the benefit of that. Mechanism of action, we already covered this. These block beta-1, which make the heart beat less fast, less hard, less strong. Indications, don't get confused there because that's not necessarily a bad thing. You'll learn more in heart failure about how slowing the heart down actually improves the efficiency of the heart because the heart gets a chance to fill up better, making each contraction of the heart more effective. What are these used for? A whole bunch of things. We use it for angina, hypertension, heart failure, for patients having an MI, for dysrhythmias, for migraine prevention, for anxiety, and there's even more than that. The side effects most commonly are going to be fatigue, bradycardia, low blood sugar. That's a common test question. As well as also these can cause sexual dysfunction. These do have a black box warning that they should not be suddenly stopped. They must be tapered down. Why? Because the heart gets used to only beating, let's say 60 or 70 times a minute because of this beta blocker. If all of a sudden I take it away and the heart rate shoots up to 80 or 90, that's a lot of extra work that the heart wasn't ready to take on. So that can cause adverse cardiac effects. Also, I already mentioned, be careful with using the non-selective in any patient has an underlying condition, such as COPD, asthma, or someone who has an active cardiac conditions such as pneumonia. Beta blockers are commonly used for hypertension in pregnancy, also known as preeclampsia. And carvedilol specifically is almost always only used for heart failure. It's very rare to see it used for blood pressure or anything else. And obviously, as an RN, make sure you are always checking a patient's heart rate and blood pressure prior to giving any medication that affects the heart rate and blood pressure. So we just did the blockers. Now let's do the agonists. So we have the alpha-1 agonist. That's going to be phenylephrine, neosynephrine. We're going to discuss this more towards the end of this lecture when we get into the actual vasoconstrictors. I'll talk about it over there. Next, we have alpha-2 agonist. This is the one that we said sort of counteracts the whole sympathetic system. So over here we have alpha-2 agonist. So this is going to increase the counteracting of the sympathetic system. In other words, blocking the sympathetic system. So that's going to lower our heart rate, lower our blood pressure. The drugs here are clonidine, methyldopa. These are two very commonly used medications for hypertension in pregnancy. Clonidine is also used off-label, sometimes for pain, sometimes for mental health disorders such as ADHD. And again, we already covered how it works. Next, we have the beta-1 adrenergic agonist. This will be dobutamine and isoprotenolol. I mentioned this in the beginning of the lecture when we talked about shock, and we're going to discuss it more in depth at the end of our lecture when we get to the vasopressors and vasoconstrictors. Next, I'm going to skip ahead to the drug class that says beta-2 adrenergic agonist. This is albuterol, very common, very well known. Levalbuterol is another version of this. How does this work? It activates beta-2, and we already said beta-2 causes bronchodilation, so that's a good thing. What do we use it for? Asthma, COPD. You may also see sometimes we use albuterol for patients having respiratory issues related to allergic reactions. The side effects of this medication are very much tested on, so do make sure you know these. We have tachycardia, we have hypokalemia, and hyperglycemia. Don't mix those up. And palpitations, which pretty much always goes along with medication-induced tachycardia or hypertension. This medication, albuterol, is always dosed PRN. The only exception for that is where patients take it in advance of exercise, where they have exercise-induced bronchospasm, which is EIB. Otherwise, this is always a PRN. It's not meant to be taken daily. If a patient's needing a daily medication for asthma, we're going to need to give them something else, and we'll talk more about that when we get to the respiratory lecture, or if you've already watched that. Levalbuterol is another drug in this class. It's very similar to albuterol. It's much less common. It is more expensive. It does, the big advantage to it, and this is the only thing you really need to know about it, is that it has less effect on the heart, so less of that tachycardia, palpitations, hypertension. So if someone has had a severe reaction or has underlying cardiac issues, or already their heart rate from the first albuterol is through the roof, then we may want to switch them to levalbuterol if that's an option. Next, we have the beta-3 adrenergic agonist. I'm not going to get really into that here because we're focusing more on the cardiac aspects of this, cardiac respiratory, but this would be mirabegron, which is more commonly known as myrbetriq. This is a beta-3 agonist. It relaxes the detrusor muscle, resulting in increased bladder capacity. So that fixes what? Overactive bladder. This does have a bunch of side effects. It can have angioedema. It can have cardiac effects. Again, because it touches beta-3, it has a little bit of touching beta-1 also, which makes the heart beat faster, harder, stronger, which is going to cause that hypertension, tachycardia. And this can also cause urinary retention related to its manipulation of the bladder capacity. Let's switch gears for a little bit and go next door from the sympathetic to the parasympathetic system. So the parasympathetic system is going to be rest and digest, and this is going to be a counterbalance to the sympathetic system. We're going to talk now for a minute about a class of drugs called anticholinergic. This is a very large class of drugs. We use it for many, many different uses. We use it for IBS. We can use it for nausea. We use it for asthma and COPD. We use it for a bunch of different things. The classic and generally the most potent of all the anticholinergics is atropine, and that's the one we're going to discuss here. But let's first talk a little bit more. Anticholinergic means anticholinergic. It's against cholinergic receptors, which essentially means it's against the parasympathetic system, which if you think about it, if it's anti-parasympathetic, that means it's a sympathetic drug. So essentially, it's going to have a lot of the sympathetic effects. So let's look at this one. The drug, the first one we're going to talk about is atropine. How does it work? It blocks cholinergic or parasympathetic effects, and technically it acts on muscarinic receptors only. I wouldn't expect that to be on an RN level exam. What do we use this for? We use this specific medication for three different things: for bradycardia, organophosphate poisoning, and for cholinergic toxicity. However, the class in general of anticholinergics have many, many more uses. The side effects or adverse effects of these drugs are what we call anticholinergic effects. And you won't always see me list them out. You might just see them listed in both my nurses as anticholinergic effects. But what do they mean? They mean everything dries up. So urinary retention, constipation because the stools get dry eyes, dry mouth. We can also get blurry vision because of the dry eyes. We can have many more effects as well. Those are generally the classic anticholinergic effects, very commonly tested on. Atropine toxicity can be reversed with a drug called physostigmine. We'll learn about that in just a few minutes. Atropine is an IV-only drug. It's not a PO medication. It is by far most commonly given for bradycardia. Organophosphate poisoning and cholinergic toxicity, thankfully, are much less common. And then there's one last thing here to know about bradycardia in different types of blocks. Next, we have drug class is going to be the direct-acting cholinergic agonist. So this would be the opposite of an anticholinergic. So the last one was an anticholinergic, and this would be essentially a procholinergic, a cholinergic agonist. The drug we have over here is bethanacol, and this is the primary drug in this class. It works by activating cholinergic receptors. This is used specifically for neurogenic bladder, and this works by causing bladder muscle relaxation. The side effects of this are tachycardia and hypotension. However, this causes the opposite of the anticholinergic, where the anticholinergic dries everything up. Cholinergic drugs have what's called sludge BBB, and you'll see this very often. You may even see this on exams. Sludge BBB is basically fluid leaking out of everywhere. So salivation, extra saliva, lacrimation, tearing, urination, defecation, or diarrhea. GI upset. E is emesis, so fluid coming out of everywhere. And then the last three is going to be bradycardia, slow heart rate, bronchospasm, and bronchorrhea, which is the lungs having a spasm, or bronchorrhea is a lot of secretions in the lungs. So those are going to be your sludge BBB. Those are your cholinergic effects. If you see cholinergic effects, same thing as sludge BBB. An overdose of this is treated with atropine. This drug class, or this specific medication, has a long list of contraindications. I'm not going to go through all of them. Next, we have very similar to a cholinergic agonist. We have the acetylcholinesterase inhibitors. So acetylcholine, we already learned, is the activator of the cholinergic receptors. Acetylcholinesterase, you may not know, is responsible for getting rid of acetylcholine in the body. This blocks that. This blocks the body from getting rid of acetylcholine. Do the math. If I block the body from getting rid of acetylcholine, that means I have an increased level of acetylcholine. So this also is a pro-parasympathetic or a pro-cholinergic medication. The drugs over here have varied uses. We have donepezil, we have galantamine, ribostigmine, physostigmine, a bunch of different drugs here. These work by, like I said, blocking the body from getting rid of it. Specifically, this drug class is most commonly used for Alzheimer's disease. However, some of these can be used for other other indications as well. The side effects of these drugs are going to be exactly the same as the ones we saw right before that, the sludge BBB. Physostigmine is a drug in this class that's used specifically for anticholinergic toxicity and to reverse non-depolarizing paralytics. Some drugs in this class are also used for myasthenia gravis, and we'll learn more about that when we get to the neurology lecture. Next, we have our vasopressors and our vasoconstrictors. So let's focus over here on our last section for just a few more minutes. Vasopressors are any drug that activate beta-1, meaning it makes the heart beat faster, harder, stronger. Vasoconstrictors are any drug that activate alpha-1, meaning it vasoconstricts. So let's go through the list. We have epinephrine, which does both, norepinephrine, which does both, phenylephrine, which is a vasoconstrictor. It'll vasoconstrict, it activates alpha-1, but it doesn't have any beta-1 effect. Dopamine, which is a little bit complex, and I'll leave it to what's written on the screen here. At a low dose, it has dopaminergic activation, which increases perfusion to the kidneys. At a medium dose, it has both dopaminergic and beta effects, and at high dose, it switches to alpha effects. I wouldn't expect the RN level to really go into the subclasses of the dose-based effects of dopamine, but just an FYI, I did put it in there. And then the last two we already discussed very briefly earlier is isoprotenolol and dobutamine. Those are both beta drugs, so they're pressors. They'll have positive inotropic effects, but they wouldn't have the vasoconstrictant. Those would not be very effective at bringing up your blood pressure, but they would be very effective at making the heart beat faster, harder, stronger. And if the heart's failing and that's the sole reason the patient's hypotensive, then yes, that should have at least somewhat of an increase in the patient's blood pressure. Mechanism of action, we covered that extensively, the beta-1 and the alpha-1. These drugs are generally used for shock, and we will go a little bit in the heart failure lecture into a little bit more about dobutamine or isoprotenolol. We'll also talk a little bit in the over-the-counter lecture about phenylephrine, which is a vasoconstrictor, because it's actually an over-the-counter ingredient in some of the nasal decongestants, but we'll get into that in another lecture. These medications generally have a black box warning that they can cause extravasation, meaning that if they leak into the surrounding tissue, as is unfortunately relatively common when people start IVs, in a normal saline IV, you get a little bit of a hematoma. When you get this, you can have severe vasoconstriction at the local area. So if, let's say there's an IV in the AC in the antecubital fossa, and now this fluid, this epinephrine we'll use as an example, starts leaking into the surrounding tissue, it's going to vasoconstrict incredibly that local tissue to the point that it can actually completely cut off perfusion to the rest of the arm. For that, we already said we treat it with phentolamine. And also for that reason, you should give this drug through a central line to reduce that from happening. Standard practice is that these medications, since they are so potent, and if we give the patient too little, then they're not getting the life support that they need out of these drugs. And if we give them too much, we could send the entire sympathetic system into way overdrive and cause them to have a heart attack and die. Therefore, we try to always have this medication be given on a pump, not just through eyeballing it or guessing the drip rate. These medications, like I already mentioned, are generally titrated and tapered based on the target blood pressure, usually systolic. and or the MAP. Usually for a MAP, we would do somewhere around 60 to 65. Usually for blood pressure, we're looking at 80 to 90 systolic. I'm not going to get into the whole permissive hypotension here. Epinephrine and norepinephrine are dosed at micrograms per minute. So get used to that if you deal with this a lot. I don't know if a test would ask you about that, but just get used to it. Dopamine is different. Dopamine is micrograms per kilogram per minute. Dopamine can cause tachydysrhythmias. Really, all of these can, but dopamine is infamous for causing that. And for test questions at the RN level, that's definitely the hot topic, that it can cause tachydysrhythmias, meaning that it can cause abnormal heart rate and a very fast abnormal heart rhythm. Epinephrine comes in both 1 to 10,000 and 1 to 1,000. You'll notice one is 10 times stronger. The 1 to 1,000 is what we use for direct injection, such as for an EpiPen or an EpiPen Junior, versus the 1 to 10,000 is what we use when we're giving an infusion, such as the traditional epinephrine infusion for shock or something like that. In case you do get asked anything about general allergies, because anaphylaxis, we do use the Epi 1 to 1,000. If a patient doesn't have anaphylaxis, or if we've already given the epi and we'll give the subsequent treatment, that's where we would get into the diphenhydramine, which is Benadryl, possibly methylprednisolone, which is a steroid, possibly albuterol, maybe oxygen if needed, things like that. And then just the last point on this whole lecture is just to go over what I said at the very beginning. Ideally, we want to match up with each type of shock the correct treatment. Not that the other ones won't bring up the blood pressure, because if I give you fluids, I will bring it up. But if missing fluids is not your problem, that's not the solution. Same thing here. If I give you a vasoconstrictor, it will bring up your blood pressure. But if that's not the problem, if the problem is that you're bleeding out, then giving you a vasoconstrictor is not the best solution. If you have any questions, please reach out to us. Have a great day.